We should start. This one? All right, good afternoon, everybody. Thank you for coming. I know it's a late session. So I'm Laura Goodman. I'm a pediatric surgeon in Orange County, California, not exactly rural, but I'll get a little bit to that later on. So go ahead.
And I'm Jonathan Kohler. I'm currently at UC Davis in Sacramento. Prior to my 4 years there, I spent 5 years in Madison, Wisconsin. So two settings where we see a lot of kids coming from rural settings. And I also am the chair of the Ask APSA committee, and it's a pleasure. This is a new committee, and this is our first opportunity to present at this body. So we're thrilled to be here.
Yeah, thanks. So we'll be tag teaming the introduction here, and then it's going to be a very interactive session. So before we start, I do want to acknowledge Maggie Gallagher for doing the breakout planning, and then Dan Roby for a lot of our background slides, and then we'll introduce each of our three panelists in just a minute after we go through our background. I have the clicker over there. Thank you. We have no disclosures. So the foundation of this interactive session, as I mentioned, interactive, is this. We don't know all the answers. We're not here to tell you the answers, but we want to establish a common path forward for the best care for all rural children. We want to work with you guys to understand some of the unique challenges and gaps in access to care for rural children. We want you all to help us identify some key strategies to approach those gaps, and then to help us in crafting an action plan to build sustainable and bi-directional or multi-directional children's surgical care within rural health systems. We really want to help facilitate your forming collaborative partnerships with your rural colleagues as well.
Now, that's a lot of work for 43 minutes and 20 seconds. So that is broadly the work of the Ask APSA committee, and today we're going to be taking some steps in that direction. Really, the work of Ask APSA aligns with the vision and the mission of APSA writ whole. The APSA vision is that all children should receive the highest quality surgical care. And within Ask APSA, that vision is to improve surgical care for children in communities that lack pediatric surgical specialists, by partnering with a broader community of healthcare providers who care for children, because we know that many children get operations in their home communities by people who do not have pediatric subspecialist training. That happens, that will continue to happen, and we feel that there's an important role that we can play and that all of us can play in helping to make sure that those kids get the best possible care. Likewise, the APSA mission is to provide the best surgical care to our patients and families by supporting an inclusive community through education, discovery, and advocacy. And the APSA mission is to develop those systems of high quality and sustainable care for children in rural and underserved environments with no immediate access to pediatric surgical specialists. How do we help the kids in these communities who don't have access to surgical specialists? And I should say, it's not always rural. It can be, there are other communities where there are big children's hospitals nearby, but they don't have easy access to them. And I think we have an important role to play.
So, where do kids get care? In 2016, general acute care hospitals provided 75% of U.S. pediatric inpatient beds. That's not surgical cases, right? We don't actually have the data to comment on which surgical cases are done where and by whom, but we can say where most of the beds are. So infants and children in general hospitals are presumably getting their surgical care from general surgeons at least some of the time in some of those locations. But we know that outcomes are better in children's hospitals in many cases, for example, intussusception, in young children with appendicitis, in treating pyloric stenosis, in trauma. So there's a real need for us to address this.
This is a complex slide with a lot of data that's been done in the pediatric space about where resources for kids exist. The key thing to know is if you live or work in an area that's white there, of which you'll see there's a lot of white, that reflects places where it's more than an hour to pediatric subspecialist care. That's a lot of landmass in the United States where there are a lot of children, ranging from general newborn care up in that top left corner down to PICU care in the bottom right corner. And I think any and all of us who were working during the triple-demic really started to feel what happens when all the PICUs are full and people are sick in the community, and no hospital in hundreds of miles potentially can accept them. This is work in pediatric specialists, we don't have this data for pediatric surgery. One of the missions of ASC-APSA that Dr. Ken Gao has been working and championing for several years now is trying to build this same sort of granular data for the availability of pediatric surgical subspecialists and create a comprehensive database of where we are and where we are not.
So let's back up for just a second and talk about what is rural. We said this is the best care for the rural child. So you saw in that last map where pediatric specialists are. Again, we are trying to get that information for pediatric surgeons and don't have it yet. But the U.S. Bureau of the Census, and this is a map from them, defines urban and rural areas on the basis of housing and population density. So according to the current delineation, rural areas are open country and settlements with fewer than 2,000 housing units and fewer than 5,000 residents. Urban areas don't follow municipal boundaries. As you can see on this map, they're just essentially densely settled territory as it appears from the air. And that's how it looks here. And that really maps closely with what you saw in that last slide. Most counties, whether they're metro or non-metro counties, contain a combination of urban and rural populations. So no matter where you live, you probably have children who are in rural areas and providers who are in rural areas nearby, people who may need your support as a specialist. And just to give the number, so of 72.5 million children in the United States, approximately 13 million are rural. That's according to the most recent data, and not all of those have great access to care, as we'll talk more about.
So there are many reasons why this is important. There are ethical bases for thinking that, justice would demand that we help children in rural areas. The APSA Board of Governors has come out and said that surgeons with proper education, training, and experience must direct the surgical care of children. Just curious, who in the room works at a CSV center, a Children's Verified Center from the ACS? Couple so far, probably a lot more in the next 5 to 10 years. One of the requirements of being a CSV center is having an outreach program to your community colleagues as well.
This is our last slide of the intro. Okay, so just to say that providing competent and safe pediatric surgical care close to home serves rural communities, rural families the best, we think, because often those families have limited resources and limited flexibility based on their work and other needs. Quality is really important. We'll talk more about that as we get into our discussion as well. And just to reiterate, we have a role and we have obligation as pediatric surgeons to improve quality in rural centers through education, through clinical support, and through other means.
All right, with that, I want to introduce our panel. You'll note in your Whova app that there is the opportunity to answer 5 polling questions. It'd be great if you could take the time to do that now. We're going to be going through each of those questions with our panel as well. So our panelists from rural Wisconsin, a rural surgeon who has on her own dime come to join us at this meeting, and a former great resident of mine when I was in Wisconsin, Annie Zeig, from Tennessee, Maggie Gallagher, and from Montana, Nick Hamilton. And we'll just give them a chance to each introduce themselves here.
Great, okay. So yeah, I'm Annie Zeig. I'm one of the ASC-APSA committee members. I became one because I was at a rural surgery meeting and Dr. Kohler, Dr. Fallett, and Dr. Riggle were presenting. And I said, would you guys be interested in having a rural surgeon on your rural surgery committee? And they said, gee, that sounds like a great idea. So I am a rural and community surgeon, and I work at a couple of different sites in northeast Wisconsin. So Wisconsin looking a little bit like a mitten, I'm kind of in this area. I work about 50% of my time at the regional hub, which is the NENA campus. That's a 150-bed level 2 trauma center that I am a trauma surgeon for, as well as kind of broad spectrum acute care surgery for adult and children. I also work at Theta Care Wapaka, which is a 25-bed critical access site, and I take call at a couple other of small critical access hospitals in our region. So between my group of about 15 other broadly based general surgeons, we cover the trauma center and then kind of a broad spectrum of rural communities throughout northeastern Wisconsin. In my role for children, we take care of healthy children. We have no desire to take care of neonatal problems. We do not cover any NICUs, but we do kind of perform a wide range of things that we feel comfortable with, including laparoscopic appendectomies, umbilical and inguinal hernias, lots of pilonidal disease and abscesses, which I'm guessing many of you are happy for us to keep in our community. And then pediatric trauma. We are not a pediatric trauma center, but we certainly take care and stabilize a lot of pediatric kids because there is a huge part of northern Wisconsin that has no trauma centers. And we are the first line in terms of the closest center before you get down to Madison and Milwaukee. Certainly we ship a lot to them. We do not have a PICU on site, so anybody who is truly critical, we stabilize and get to the resources they need.
Great. Maggie?
Hi, I'm Maggie Gallagher. I am a lieutenant colonel in the Army, and my kind of background is I finished fellowship in 2019 at Vanderbilt. The Army sent me down to San Antonio, where I was the only pediatric surgeon at the hospital down there. Initially, I had a contract with the local group of pediatric surgeons that could help me with some call coverage in bigger cases. The hospital then cut that contract and then closed our PICU temporarily. So that kind of started a lot of the decision making as far as when to transfer kids, what's safe to do for kids. And in this setting, it wasn't rural, so completely kind of different mindset. I then had the opportunity to come back to Nashville. I am a general and pediatric surgeon up at Fort Campbell, which is an hour plus outside of Nashville, and that's with no traffic. There I took the job of chief of general surgery, where I work with all the general surgeons that are up there. And it's given me a really kind of interesting view of a small community hospital. Our hospital is actually 47 inpatient beds, which definitely are not filled all the time. And right before I got there, they actually stopped admitting any peds and said we can't admit under 18. So we had general surgeons that were doing some younger appies, often with the conversation with the family of, hey, we can send you down to Nashville, or I'm comfortable doing this as a general surgeon. But right before I got there, they said we had to send out a 17-year-old, 300-pound appy because the hospital, the nurses and the floor and everyone's not comfortable. So that's kind of sparked a lot of my interest in this concept of what should be done outside of major cities and by general surgeons.
Nick?
Sorry.
I'm Nick Hamilton. I'm a pediatric surgeon who works at Community Medical Center in Missoula, Montana. Missoula is a town of 70,000 people, so it doesn't meet the rural classification. And I think that it's interesting because in Western Montana there are three pediatric surgeons between two different hospitals. Ronan Aurelius was actually here earlier. I didn't see her come in the room, but she works up in Kalispell. And she's more of a technically rural surgeon than I am, in that she covers, Kalispell's like 21,000 people. But from a facility standpoint, she has like a state-of-the-art, brand new modern hospital, which I'm kind of jealous of, because I still don't have towers for laparoscopy, or that we use towers for laparoscopy because we don't have the rooms that are laparoscopically set up. But it is a 151 bed, adult, mostly adult, and that actually counts our 34-bed NICU in those 151 beds. It is the major birthing center for Southwest Montana. We have a 2 to 3 bed PICU, and we have about 20 total pediatric ward beds. And a lot of what I've done since I've been there for the last 2 years is kind of bread and butter general surgery, appies. We do have a pediatric gastroenterologist, which is great. And we actually have a really good working arrangement with the adult urologists and the adult ENTs for airway foreign body coverage, gastric foreign bodies. I do the esophageal foreign bodies. She does the gastric foreign bodies, is kind of the agreement I have with GI. And kind of, I think in talking today, but also in the many committee meetings that we've had, I think that one of the take-home messages is that every hospital is a unique flower in terms of like what resources they have, what resources they don't have, and a lot of what's going to have to happen in terms of like coming up with a plan is going to be on a very local level with what people where you are have, or what you have the ability to take care of, and working with them to arrange it. And so just, I'm happy to see everyone here that has an interest in this and helping, make care better for kids overall.
Great, thank you guys. We've now got half an hour to go through some of these questions that are in the polling. We'll have the panelists respond, and then also I want to open this up to a conversation with all of you here. So the first question was, should all children in rural areas needing surgical care be transferred to a children's hospital? And there are 51 responses. 12 say yes. And, there are 52 responses. 40 say no. So I'd be curious to hear from all of you. Annie, what, obviously, I'm guessing you're in the no camp.
I'm in your camp, and some of that is a personal bias because my favorite call case is a 10-year-old healthy Abby that I could make better and get home, very quickly. Save parents the travel, save a lot of hassle and headache, especially for some of our vulnerable populations, our Amish community, our Mennonite community, our immigrant communities in a lot of our smaller areas. I also, every time I see this question, I think of the spectrum of what is pediatric care, and the 17-year-old, 300-pound Abby, is that somebody that we should be transferring? Is that someone who needs to be? Or same with the, buttock abscess on a 16-year-old. Where is that line? And I think we're constantly trying to find it.
Maggie and Nick, in your communities, when people in the rural communities you serve want to send patients, who are they sending? Who are they keeping?
I mean, for me, anyone they call about, I'm going to take, right? Because I still have that academic mindset of it, and and it's a call for help that they need help. And what usually happens is it's usually the conversation of when it's the surgeon, they're calling and they're like, I would do this. I don't have pediatric nurses, or our hospital can't admit kids. And so, there are children that are presenting to those areas, and they want to, and they just can't because of administrative reasons, where they don't have the ability to admit them afterwards should something happen. For me, there are cases that I don't do. I don't do Kasai's anymore, because even though we do have a gastroenterologist, she's booking into September for cases. She's swamped because she's the only one. And I don't want to put the burden of having her, between the two of us following any kids who have biliary atresia. And so there was a patient that was a rule-out biliary atresia that we sent out. We don't do ECMO, so clearly I'm not doing diaphragms. And so there are kids that are a case-by-case basis, and the degree of complexity that, because of the resources I have at our hospital, we don't keep, even though they do have a pediatric surgeon, we do have a PICU, there are kids that we do not keep.
And so my story about the 17-year-old, we've shifted some of that, and I've been able to get the admission age for kids down to, we're kind of sitting between an 8 and 12 range, depending on the day and the nurse that's on. But I definitely don't think, a 15-year-old with appendicitis needs to be transferred. And I think the majority of parents are comfortable with a general surgeon taking care of their child. I recently just thought of the fact that I was 10 when I had appendicitis, and grew up about 30 minutes outside of Milwaukee, and definitely a general surgeon did my appendectomy, and I think I did okay.
Annie and I both sit on the Northern Plains Rural Surgical Society, so there are actually very few sort of centralized bodies of rural surgeons, and the largest is something called the Northern Plains Rural Surgical Society that Mary Fallett got me into. She's been going for years. It's about 60 members. Obviously, there are many, many more rural surgeons than that, but that is sort of the consistent thing we hear when we go in and speak to rural surgeons is they would be very comfortable in many cases operating on children and being active with children, but there are many limits to their ability to do that beyond their own comfort. Things like, will anesthesia do it? Can the nurses recover the patient? Do they have a bed to go into? And I think a lot of that has gotten worse with COVID when pediatric wards were converted to adult wards and never converted back. And there are economic reasons for that, but they've really, the pediatric capacity has really declined. I think those maps that we showed earlier, if you showed them today, would be even worse. One of the things that we hear a lot from pediatric surgeons, or from rural surgeons when we go and talk to them, is that the thing that they would most want to have from a pediatric center is the phone number of a pediatric surgeon they could call. So that's our second question. Have you personally shared your personal phone number with any rural surgeon in your area to help them make clinical decisions about patients? And we're almost perfect 50-50 split. 27 of 51 yes, 24 of 51 no. So I would love to hear from the audience about your experiences trying to engage with your rural colleagues and why you do or do not share your number.
Hi, Jim Pierce, Central California. We're just south of you, and we're right by the UCSF Fresno training program. And so as the residents come through, actually 100% of them get my phone number, and I encourage them as they're going off the rotation to call me. Over the 10 years that I've been there, though it's been quite difficult to reach out and meet and get to know some of the rural surgeons, especially people over by the coast, like in Santa Maria. And I'll be honest, one thing I might ask from Ask APSA, or one thing that would be what these organizations could really help us with, is finding pen pals, right? Finding somebody helping us get together and get those contacts, or maybe sponsoring an event where we go to an area instead of trying to go to the offices of the pediatricians to sell ourselves. We should go out and meet the surgeons and just get to know them, and have some lemonade and hang out.
Is there anyone here who has had lemonade with their local pediatric surgeons or their local rural surgeons? Any tips or tricks for finding those people, getting into their offices, setting up a meeting? We have a couple resources that we will talk about before we finish today.
Yeah, to your question, I'm Kathy Shaw. I'm at Children's Nebraska, but I'm actually from rural Nebraska, born and raised, and so it was very easy to get in with the local pediatricians, because some of those were my pediatricians, and so some of them I rotated with through med school when I went to UNMC. And so just getting the word out, and then they passed it along, and I would go meet with them, and then they were so amazed when I was like, here's my phone number, just call me, it's fine. And they absolutely loved that. And then they're like, do you mind if I pass it along? I'm like, yes, please do. Because it's those kids were me back in the day, and those are my best friend's kids. And so it's very helpful for them to they just call and ask questions like, hey, would you see this in clinic? Do I need to be worried about this? How urgently do I need to send it? And occasionally it's hey, this butt doesn't look right. And then I'm just send them down. I have clinic today. I'll see them. And turns out was an anal rectal malformation with a perineal fistula. And it's thank you. And they were oh, that was really easy. And so I think that that's super helpful. And so it's just spreading the word and being I'm not the stereotypical surgeon, I'm nice, and approachable.
I think all of us would probably say that of ourselves. We're stereotypically non-stereotypical in pediatric surgery. What's your guys' experience in terms of being reached out to or reaching out to pediatric colleagues?
I was going to say, I think also a general surgeon having your phone number and just hearing, yes, you agree with what they're doing is huge, or you saying yes, it's appropriate for you to do that, because then if they do have a complication that we could have as well, then they kind of already have that confidence in that they spoke to somebody and that you've reassured them, and
Permission to have the complication, basically.
yeah, a little bit. And also but I was glad he said about giving all your residents your number. So in the military, we obviously are training residents to go sometimes to places that aren't that close to a major city, and being able to get those phone calls and say, hey, what would you do with this? One of the recent ones I had was an Air Force resident in England, and it's actually really hard for them to get kids to their local community there. And it was a kid that swallowed a foreign body, and she's like, I'm following this, like, how long do I wait? Because I feel like I should operate, but how long should I wait? And just, I think the reassurance of, it's okay, take your time, he'll be fine. Save that kid potentially an operation.
Hey, my name's Tara. I work at Geisinger Medical Center in North Central Pennsylvania, which is, the hospital is bigger than the city that it's in, but serves an enormous catchment area of rural southern New York, North Central Pennsylvania. So we have a lot of outreach that we do, particularly in the trauma setting, where a lot of the hospitals around, it's kind of like wheel and spoke, like we're the middle, and there's a lot of spokes that come to us. So we'll often go to even virtually go to their ER monthly meeting or their trauma committee monthly meeting and say, if you are on the fence about scanning a kid's head, but that you're going to need them admitted for observation, just send them. And they're so grateful just to hear that. They're so grateful to hear, you don't have to have an imaging finding for us to see one of your patients. The other thing that we have is something called Ask a Doc. It's built into our EMR, where physicians within our system, at least, can send us whoever's on call that day and Ask a Doc, and they'll usually have pictures or some sort of imaging finding and be like, what do I do? What do you see this? Or is this, craniofacial, or is it urology, or is it neurosurgery? And so many times I can triage things from my computer and say, send them to clinic today, or, we usually follow these symptomatically, or, consider getting this test or this image and send them to clinic. So that's really helpful, and that's built in. I feel privileged because we are already in kind of a system. So many of our referrals are very built in, and we are kind of the only place in that area too. So and I think everybody knows how to get in touch with Geisinger, but part of it just is the idea of saying yes to everybody, which is basically like, just say yes, because I think, if people are calling you, it's because they need help, and it may not be a surgical problem. It may end up being a GI problem, or even like a renal problem or some other problem, but people only call because they need help.
Do you mind if I ask what your EMR is that you have that set up? 'Cause that's
We use
amazing.
Epic,
You
and
it's through Epic?
yeah, and it's built into it. And I'm not sure if the user has to be part. I think the user has to be part of like some Geisinger hospital, which there are tons of. But they send this Ask a Doc referral, and we spend some time looking through the chart. We fill out an answer, and then we route it appropriately. And I can route it even to like my clinic nurse, and they'll call the family and make an appointment. So a lot of times too, what we'll have, because we have clinic every day, not always, me personally, but we have clinic every day. I'll have ER doctors call me in the middle of the night and be like, have this inguinal hernia, I got it reduced. It was incarcerated, I got it reduced. Can they see you? And, but what should we do? I'm like, well, just send them to our clinic tomorrow, and I'll type out a message to my clinic nurse to make sure that they get in touch with the family. And we have kind of a flexible clinic schedule. Like, you basically can just show up anytime. And there's no like other clinics where like, if you miss your appointment by 15 minutes, you have to reschedule. But yeah, so that is, I think, something that works well.
It's a fantastic setup.
Yeah. Anyone else have a similar system or similar experience with Anyone else have Ask a Doc? Easy access.
Annie, when you're like in the OR with a nappy and something's just weird, who do you call?
Yeah, that's where I'm super grateful to be in the state that I trained, because I do have every number of every pediatric surgeon that I train with. That being said, I don't have any of the numbers at the other tertiary center. So that's what I'm working on building relationships with. I'll say I love the lemonade idea because I want to know, and I think most rural surgeons want to have a sense of your whole group. As much as I want your number, every time a weird CT scan comes in, it's 2 a.m. And if you're not the one on call, I do not want to call you at 2 a.m. because I don't want to be called at 2 a.m. when I'm not on call. The other thing I'll say is that I think something we underutilize of our community relationships is, once kids get through whatever big trauma event they had and they're back in their communities, how can we leverage some of those relationships to keep kids locally for some of their aftercare? Like if there's a traumatic wound that's basically healed, maybe they don't need to drive the 2 hours to see you. Maybe I can shoot you a picture from my office and provide some reassurance or some wound care. If there's a G-tube that needs a little silver nitrate on it, I mean, shoot, I'd be happy to see that kid in my clinic anytime, save you guys for doing some of the big, bad, important stuff, and keep that kid closer to home and keep their parents at work.
There's some good studies on G-tube complications where the average length of travel for a G-tube complication in the Midwest is 4 hours. That's a long way to drive for silver nitrate. I mean, what are you guys doing, Maggie and Nick, with your rural communities? Do you have that sort of trade-off with complex care kids in the community where you have co-management or?
Yeah, there is a little bit through. So we are not a trauma center, and so let me step back. We are not an ACS verified trauma center. We're a state designated community trauma center, and so we have a very interesting relationship with the Level 2 trauma center. It's an adult trauma center in town, where there are patients that will be initially seen there because they meet the state has criteria for what becomes different where they're supposed to go, where the rig is supposed to take them. But sometimes they do come to us, and we're sorting out if it's like an EMTALA violation or sort of thing, because it's technically a transfer down in a level of care, but it's to our PICU. So is it really? That's then the fun sort of stuff that I've been trying to figure out. It's all that administrative stuff, but so we do have a relationship with them, and then and there will be patients on whom they operate for bowel injury or whatever, that they do come to us even though we're in town, but because we're just more familiar with kids, we're kinder, gentler people, and everyone that knows me knows that's not true. But we do kind of coordinate the care with that. We've the kids that have polytrauma, bad head injuries, spine injuries, very complicated ortho injuries that end up having to go to Utah. Katie Russell, took excellent care of a patient. The kid was in their hospital for over a month with an open abdomen. That was taken care of in Montana and then transferred because they had multiple spine injuries, a head injury. And, kid showed up back in our clinic and, got on the phone with Katie, talked to her, and kind of sussed out what all happened. And so we do have those collaborations for the kids that we have to send out even, so.
This is just a follow-up on that phone call, right? So if you give out your phone number to rural surgeons, do you never get a moment's rest? So how many phone calls do you get per month from a rural surgeon? 15 of 47 say none. 16 of 47 say 1 to 2 per month. 9 of 47 say a moderate number of 1 per week. And some say frequently, multiple times per week. I'd love to hear from someone who is frequently speaking to their rural colleagues.
Andrew Ziegler from Portland, Oregon. So when we have a Surgeon of the Week model, and so when we're on, we get calls from ERs all over the state and adjacent states, and they're mixed ERs that have adult and pediatric EDs. and also from general surgeons who are seeing a kid, you know, who had their perf DAPI 3 days ago. They're not quite getting better, just looking for some advice. And so we field quite a few of those calls. And at the end of each one, does anyone have a phone on them? Does anyone have a phone? A phone that has apps? There's an app that I recommend to them. It's the app that we use in our pediatric surgery division. And you can look it up now. You can go to your app store. And it's called OHSU MVIPS. OHSU MVIPS. And so Elizabeth Fialkowski, one of the faculty at Dornbecker, really spearheaded this. And it put together, it's about 25 or so of our protocols, of our clinical pathways. And it's some stuff that you may not be using in a rural environment, like a post-op anorectal malformation clinical pathway, but stuff like, you know, how we're managing pneumothoraces, you know, how we're managing perianal abscesses in infants, you know, how we're managing acute appendicitis and perforated appendicitis. And that's one thing that we try to disseminate out there.
Sorry, how are those doctors at the other hospitals reaching you on call? Are they just going through the hospital operator?
Yes.
So they're calling your hospital and then they know to put the person in touch with the surgeon?
That's right. That's right. And they're happy. They're grateful when they're able to get that information so they can use it in their own practice.
Hi, thank you. Abigail Martin from Lexington, Kentucky. So we have, so I'm at University of Kentucky, and I don't know if this is true, but when I started there, we were told that our emergency department at Chandler Hospital is consistently gets the highest number of transfer in calls and admissions to our ER in the country. And so we have a very robust kind of operator call referral system. And so we constantly get phone calls, but it's often from the emergency department. It's not from the surgeons themselves. And so I've often wondered, you know, when you ask these questions, I don't even know if the general surgeons in the rural areas are ever involved in these conversations or if it's going directly from the ER to us. And certainly when we're on call, we get phone calls all night, all weekend from the emergency room physicians. But it's just incredibly variable, and I'm guessing that the vast majority of the time they are not speaking to a general surgeon in the local area.
Yeah, we found in the triple demic, I expect I'm not alone in this, but that when we didn't have beds and we were getting calls for 17-year-old API transfers from emergency departments, when we said, have you asked your general surgeon if they could possibly take care of this? Like, we'll figure it out if we can't, but if you could take that kid, it would be awfully nice. Frequently, they would call their general surgeons who would do it. It was fine. All right, we've got only a few minutes left. So the youngest age that hernia repairs are done by general surgeons in your area? 4 of 48, 0 to 1. 5 of 48, 1 to 5. 9 of 48, 6 to 10. And 30 of 48, greater than 10. Annie, what's the youngest you'll do?
I did a healthy 2-year-old a couple of weeks ago. That is the absolute youngest. Yeah.
And what's the limit? Is that your sense of like what your technical threshold is, or is it anesthesia or nursing?
In general, it's a combination. Definitely, our anesthesia team has said nothing less than 1, and I totally agree with that. And yeah, just general comfort, the ability to have general resources, nursing resources, and yeah.
Because you don't have any pediatric anesthesia providers.
Correct. Yeah, I have highly experienced, good anesthesiologists, and that was a must when we put together this case for this 2-year-old. But yeah, that is the biggest thing we're lacking.
And important to note too that, and Ask APSA has done a lot of work with our colleagues in anesthesia. Many rural hospitals do not have an anesthesiologist at all. There are many states where CRNAs are able to practice independently. In many states where CRNAs are independently doing anesthetics on very, very young children in rural communities. And so huge opportunities outside of the realm of this room to engage them in best practices, just like, on the other side of the blood-brain barrier, who is putting these kids to sleep can be very, very, very variable. And I think just like us, they want to be doing a good job. All right, and finally, how many times a year are you visiting community hospitals in your area that do not have a pediatric surgeon on staff? I don't want to take it. I just want to see the answer. All right, so none, 0 times, 32 of 46, 2 to 3 times a year, 6 of 46, and more than 3 times a year, 8 of 46. Can we hear from some folks who are doing that more than none? What are you doing? How are you making those relationships? What brand of lemonade are you taking to the rural surgeons that they keep inviting you back? No one wants to own up to visiting their rural surgeons 3 times a year?
I think that one opportunity for people to do this, and this is something that I did as a resident when I was doing my pediatric trauma research year. The rural trauma course through the college is it's based in the hospitals where you're teaching the course. And so you get to go, and we would go from St. Louis Children's down to the Boot Hill of Southeast Missouri, and you go to these, critical access hospitals, and you see the resources that they have, and you're teaching the, it's usually a family medicine provider who's the one that covers the emergency room, how to triage and ship, as fast as they can, stabilize and ship. But you get to do it in their environment, so you can you have to modify what you teach them because you're actually seeing what they have to work with. And what it makes you realize is once you've done that once, every time you get a phone call or a transfer in from that hospital, you're like, you did a fantastic job because I know what you're working with, and I would never have been able to do what you did with that patient in that environment. And it gave me a much greater appreciation for just how hard it is for the people in those rural environments to take care of the patients that they don't see a ton of, that are really, really ill, and are able to package them in a way that, it's not what you would do at your facility, but it's way better than they should be able to do with what they actually have. And all you have to do is take the course once, and you can become an instructor. It's kind of like Stop the Bleed. And then that's a good avenue for you to get out and reach into these smaller hospitals and go actually interact with the people who are sending you patients. And they love that the pediatric surgeons in St. Louis were doing it, because they had so many pediatric questions such that we actually added a little, an extra half an hour to our lecture, just pediatric trauma focused, in addition to all the adult stuff that we would talk about.
Yeah, I think we get hardened and stop remembering that it's terrifying to take care of children. But for people who don't do it all the time, it's scary, and I think we can be a huge resource. We only have a couple minutes left. I think the key points we wanted to reiterate in this session were that we have a role in training not just future pediatric surgeons, but surgeons who go out in the community and take care of children, whether they have a pediatric degree or not. That there's a huge role for continuing education and knowledge sharing with rural providers. Mary Fallett is part of Ask APSA. She inaugurated this group as a task force, then became a committee, and her primary project in that time has been developing a rural subtrack or a pediatric subtrack for acute care surgeons. That program now exists as of this year, and is training acute care surgeons to have a little bit of extra expertise in the management of pediatric, really trauma and critical care. There's opportunities to engage with Ask APSA. We'd love to have anyone who wants to partner with us. And also we are engaging with other professional societies, as I said, like the anesthesiologists and anesthetists. And we're working very hard to develop some data-driven protocols and understanding of what's going on out in the community, because I think we still are sort of operating in a data vacuum about exactly who's getting what operations by whom and where. And without really understanding that, a lot of potential avenues for advocacy are closed to us. I want to close with a series of resources. And there are these QR codes are also on the tables around you here. The Education Committee has put together an amazing compendium of knowledge about pediatric appendicitis for people in rural, for community settings, rural settings, and deployed and humanitarian settings. Ask APSA has a website here. We, as part of that, have developed and are piloting now the first of what I hope will be many modules, short talks, like 15, 20-minute talks. The first is on appendicitis that you can take, modify for your own audience, and use as the avenue to go out and talk to your rural surgeons or hold a Zoom meeting for all the rural surgeons in your region. We want to build those resources for the membership of APSA so that they have prepackaged talks that they can use to make those first introductions to their community. Our only ask is at the end of all of them, just give them your phone number. The rural surgery training curriculum is extraordinary. Maggie's done a lot of work as part of the Education Committee putting together a whole curriculum for rural surgeons in that community, rural, and humanitarian deployed environment that you can point people to. We, as Ask APSA, if you go to the Ask APSA, or the Ask APSA website, on the APSA site, there's a link there to a $50 subscription to Ped Surgery Library Expert and NAT for people who work in facilities that do not have pediatric subspecialists, so they have a vastly discounted way of getting access to pediatric specific information. You mentioned Katie Russell. I mean, I think Utah sort of leads the world in outreach to rural centers, specifically around trauma, and their website is a great example of how to do that. It sounds like OHSU has a similarly excellent program. Peds Readiness in the EIC is developing trauma protocols for rural centers who take care of children. And as I mentioned, there's the AAST Fellowship that Mary Fallett has put together and is an extraordinary thing. So with that, we are out of time. Thank you all so very much for coming. We'd love to talk more about opportunities to reach out, but please do go home and give your neighbors a call. Thank you so much.